All right, thanks everyone. Excited to see how many people are here in person. I love that the closer we get to the end of the year, the more love that I get. I know, it's just like, I get all the fuzzies in the burr months. Like, so welcome to September. Hello, wake up. Maybe not, okay. So, per usual, just want to remind everyone, trinityhealthofne.org/ems-classes is where you will find the links for everything that we're offering. It has all of the M&Ms as well as some new offerings that I'm going to talk about in just a minute. TH of NEEMS on Instagram and Trinity Health of NEEMS on Facebook. A new feature that I'm working with, offering with marketing, is every month after the M&Ms, we're going to be posting on social media like summaries of some of the teaching points from the M&Ms. So if you want some spaced repetition on your learning, follow us on there. You'll be getting that. Also, the first part of the M&Ms, which is, now kind of the new format, we do kind of more like a lecture up front, and then we go through some cases to apply what we learn in the lecture. The lecture portion is recorded and posted on YouTube afterward. So if you have a coworker that you think would be interested in what we talked about, the recordings of that are also on this same webpage. In the recording section, you scroll down to the bottom, they're right there. So I have to put up a couple slides for the blah, blah, I don't take money, no one actually pays me for anything, barely even Trinity does, for the continuing education stuff. So new classes. I've partnered with the ED nursing team to give you guys some additional learning opportunities with them for the stuff that they teach for part of their new nurse orientation. So if you're an EMT basic that's considering going to paramedic school, there's an EKG class that they offer quarterly that you're welcome to come sit on. That they go through rhythms, and it's the same stuff that someone has to, a nurse has to go through if they're going to be sitting like on a telemetry floor to be able to monitor telemetry and stuff. I don't think most paramedics would get anything out of it, but if you're an EMT basic that's considering going to medic school and you're kind of like really nervous about rhythms, that's an opportunity. We also have a critical care medication class where it's the ED nurses that are talking about all of the drips for pressors and sedatives and other stuff that we use in the ED. They talk a little bit about a few things that are not within the ALS scope, but most of what they're focusing on is, because they're talking about Levophed and Epi and all the other stuff that are within the scope if you're within an agency that's using pumps. As an update, for like pharmacy-wise, when you guys are dropping off patients in the ED, all nurses now have access to the EMS Pyxis. There was kind of some confusion before about who did or didn't have it, and maybe it was only charge nurses. So whoever you give report to should be able to grab whatever meds you need out of the EMS Pyxis, okay? So you don't have to track down the charge nurse or anyone. Any nurse that's available should be able to pull meds for you from the Pyxis, okay? So hopefully that makes your life a little bit easier. There are flyers in the EMS room with some QR codes you can scan. That will be updated because I screwed them up the first time. For one is if you have a case you want follow-up on, just put in the patient information and who you are and who the patient is, and then it'll submit it into a form. We'll get an email to know to follow up on the patient, and then we'll send the follow-up to your agency instead of having to go through the extra steps to email your coordinator talks to my coordinator. This is just put in the form, and then we'll take care of it. And if you have an interesting case, right? This is the one that, the EKG gets put on the fridge in the kitchen at the station or something, or you guys are talking about it around the kitchen table. Let us know about it, because those are good learning cases that we want to feature in the M&Ms, right? Because the M&Ms, I think you guys have learned by this point, the way that I do these, it's not about what you messed up, okay? It's about good catches. I know, I can see your brain exploding. It's about good catches. It's about cases that have like good teaching points. And it's about, growth opportunities. So it's not just about like, you missed this and this is what you need to do better. Like, that's not what it's about. So if you have interesting cases is. Let us know about it, right? And so there's two different forms you can submit. There's a problem with the interesting cases if you're trying to attach like a photo EKG right now, but I'm going to get that fixed. If you're calling for MedCon, just call one of the recorded line phone numbers directly. That meets all of the regulatory requirements for it being recorded because it's recorded on our end. You don't have to go through CMed and ask for patch. So if you're calling, that'll save you a significant amount of time by just cutting CMed out of the loop. If you have a phone, if you have to go through radio, then you're stuck with getting a CMed patch. But otherwise, just call us directly on one of the two recorded lines, and that meets all the requirements, and it'll cut a bunch of time off you trying to get someone up. In addition to the normal November M&M, we're also at the request of the guys down in Hartford. I'm going to be doing an online journal club where I'm going to be talking about recent research papers on ketamine. So if you're interested in learning what the most recent research and data say about the safety and the use of ketamine in the pre-hospital setting, I'll be analyzing those research papers, explaining them, and explaining like how you can read and analyze a research paper on your own. And that's available for OEMS hours. It's not an M&M, but it is CME hours. Yeah, it's 2 hours. Right. So if you're here in person, please scan the QR code to participate. I'm not even sure that did I even start the right app? I don't think I did. Nope, I didn't. Scan the QR code to participate and log in. If you're online, please try and scan the QR code to participate. That's easier if we have all of the responses in one place that show up on the screen. Otherwise, they will show up in the chat. It's just that when you respond to the polls, it won't show up with everyone else's. So we'll go with the first question. By a round of applause, how do you feel? Just mark on there. All right, pretty good. Overly positive. Oh, I like that someone put almost like a tear on one of the eyeballs. Okay, good. So polls are working. So this month we're talking about neuro, mostly focusing on seizure and stroke. So first we're talking about seizure, and I want to reframe the concept of seizure as loss of consciousness plus convulsions. Okay, and that could happen for a variety of reasons, one of which is syncope. So how do you differentiate seizure versus syncope? Okay, so we got LSD without convulsions, postictal period, extended time of unconscious, convulsions, history, return to baseline after episode, alertness post-event. Okay, good. Postictal period. Okay. So we got a lot of tonic-clonic movements, patient history mechanism. Good. So we got a lot of thoughts focusing on really kind of the history of like what was seen and what does the patient look like afterward. So seizure versus syncope. Seizure, again, these are all generalizations, right? So seizure beforehand, the patient can have an aura, which means they can kind of tell that it's happening. They may have focal symptoms or olfactory hallucinations. The classic description is like smelling something that's like burning. Versus before someone syncopizes, they have symptoms like palpitations, diaphoresis, dizziness, lightheadedness. In a seizure, they may have the myoclonic jerks before the loss of consciousness, because what's happening there is the seizure is starting in one part of the brain that controls the motor portion for the place that's shaking, and then it generalizes to the entire brain when they then have the loss of consciousness and the full body shaking. Whereas in syncope, you can still have some of that myoclonic jerking, but it's going to occur after the loss of consciousness. Now, this is going to be very difficult to know unless you witness the event, because if you ask your average bystander, they're not going to have a clue, or each time you ask them, they're going to change their answer, right? Seizures are usually, 1 to 2 minutes unless they're in status. Syncope usually less than a minute. In a seizure, the blood pressure and heart rate will generally be elevated, whereas in syncope, they could be low. They're not necessarily, but they could be. You're like, oh, well, you lost consciousness and you were kind of twitchy in your bradycardic. Yeah, probably more likely you passed out, right? Again, we talked about post-ictal confusion. A lot of people brought that up. Good. Versus the very rapid recovery to baseline. Eyes in a seizure, you've more often got horizontal eye movement versus in a seizure, you have like the rolling back or the vertical deviation is more common. And in a seizure, they will generally, they may have their eyes open or may generally have their eyes open versus in syncope, the eyes will be closed or rolled back. And in a seizure, classically, you've got that lateral tongue biting versus the front of the tongue biting in syncope. That's not terribly reliable for discriminating the two, but it's just, if you're being really thorough and you're doing a mouth exam on all your neuro patients, it's one more thing to kind of help you lean one way versus another. So this is a bunch of videos where they took, it had to be the Germans, German college students. And I cut out the part before this, but they have them like crouch down and like hyperventilate. So they're basically vagaling and hyperventilating, and then they stand them up and make them pass out so that we can watch what's happening when because these are all syncope patients, okay? So it's like, okay, you lose consciousness and you're twitching, right? Like a bystander might call that a seizure. Some of these get actually fairly impressive, where if I saw it, I'd be like, I think that's a seizure. This is one of the less impressive ones, I think. I think he has a good one. Right? It's to the point where you're like, are they seizing? Oh no, hers is the really good one. Right. They're still pretty brief and they're going to have that rapid recovery. But even if you witness this, you might go, I don't know, was it a seizure? Especially that arm kind of movement. But again, you can see that these episodes are mostly lasting just a few seconds. But you can easily see where if you arrive on scene and the patient's kind of, back to baseline or maybe just like a little bit out of it, because even after syncope, people can be like a little bit out of it. Based off of the description from the bystanders, you could easily be convinced that what they're describing was seizure activity, when these are all 100% vagal syncope patients, right? Because they induced vagal syncope in them. I like how he's just like, what? I also love how you can tell from the facial hair, like exactly what era this was all done in. So it's looking at the eye movements, a close up of the eye movements in the syncope patients. And you'll actually see a fair number of them seem to have that like horizontal. So they're kind of like rolling back. Then eyes closed. Kind of more horizontal deviation of that patient, but then the eyes closed pretty quickly. kind of stays more in the midline, but then the eyes are closing fairly quickly, then opening again. So those are like true syncope patients, right? Another group that falls into this is cardiac arrest, or as I call it, really bad prolonged syncope. Sometimes it's kind of endless syncope, right? So patients that go into arrest in front of you, you can easily mistake for having a seizure. And that's because they're going to have some of those movements that look like those syncope patients. Only it's not because they vagal, it's because they're in VFib. Okay, so I've talked with medics through cases afterward where they were like, yeah, and this, and then I was like, you know, we gave him the Versed, and I was like, does this guy have a pulse? Like, did I kill him by giving him Versed? It's like, no, you just, you know, Versed is not in ACLS. So, it's a new update. It's in the new update. I'll be out later this year. So this is, again, it had to be the Germans. This is a girl that's in a seizure monitoring unit because she keeps having these episodes or spells that they think are seizures. So she's on a video EEG with a cardiac monitor, and the EEG is most of the rhythm strips. The cardiac monitor is the bottom strip. So she's starting to feel symptoms. So she is going to ring the bell. Can you guys see what the rhythm is? She's in torsades.
Sagen Sie sich bitte, das war Tisch. Können Sie mir Ihren Vornamen sagen? Wissen Sie Ihren Vornamen? Können Sie bitte mal die Arme nach vorne strecken?
Now, to be clear, they actually don't have the telemetry available in the room.
Vornamen?
So this tech who's like reassessing the patient, this isn't a nurse, has no idea what's going on other than this is the
Können Sie
patient
mal
who's
die
having
Arme nach
symptoms and
vorne
push the button.
strecken?
And so this is like, they're doing like their standard like, oh, you're having an episode like seizure assessment for someone.
Können Sie mir Ihren Vornamen sagen?
She's not seizing. Yes.
Können Sie mir bitte Ihren Vornamen sagen? Wissen Sie den? Können Sie mal die Arme nach vorne strecken?
Yeah.
Können Sie mir Ihren Vornamen
Voice like
sagen?
Versed. Just. This is the point where you're like, she looks kind of dead.
Können Sie bitte mal die Arme
This
nach
made
vorne
me itch so
strecken?
much the first time I watched it. Maybe you're having that experience right now, just like seeing that monitor with no cardiac intervention.
Wo ist denn die Glocke für die Schwester? Klingen Sie mal, bitte. Können Sie... Haben Sie gesagt? Ja. Okay. Signal. Kommt er hin? Ja, dafür hat die Klinik. Ich werde mal ganz schnell kommen, ich weiß nicht, sie atmet kaum mehr und er fällt auf die Seite auf jeden Fall.
All right, at least we're in the recovery position now. Not quite chest compressions, but I'll take it.
Ja, die soll auf der Seite bleiben. Okay. Was hat sie da mit dem Kopf? Sie hat den Kopfhörer drauf.
Well, I guess it worked because she's back in science.
Hallo.
Hello.
Halte sie mal auf.
Yeah.
Ja.
This is my favorite line that she ends on here.
Jetzt atmet sie wieder.
Okay, now she's breathing again, and then. She had a seizure, clearly. Right? Right? And like you could have like a patient, oh, they're like weird and kind of out of it. And like if you're BLS unit and you don't have them on the monitor, sure seemed like the patient had a seizure if you're not sitting there feeling for a pulse. And even then, like you've got that kind of breathing, right? You're like, well, they're breathing. I mean, that was honestly, especially when you have those kind of pauses and you're like, that's agonal, right? Right. This is it's a BBC show called Helicopter Heroes, where they follow HEMS crews around the UK. This is a much older episode. You'll be able to tell. So there's several videos. These are several videos of like cardiac arrests that were caught on camera. But many of them are much older. So keep in mind, this is like CPR ACLS from like 20 years ago. So don't be like too quick to judge. Those of us that have enough gray hair will recognize the life pack and be able to tell you what era this was, right? But he's a dispatcher that started having chest pain.
But no problems, we're on his way, Chuck. Cheers, love, bye.
You know, anything along the last one, no diabetes, epilepsy.
So he was one of their dispatchers, and the crew they're not on a call. He just started having chest pains. Yeah, exactly. Everyone old enough knows immediately how old this is. Because obviously if it was on a
ECG
helicopter,
looks a little bit dodgy at the
right?
moment. Not 100% sure what it is. Okay, but we'll just err on the side of caution. It's just going to mean a trip down to LGR. Okay, let's pop that up there for us.
Yeah.
No, it's probably one.
Just pop it over to my finger.
Pop another one.
God, a lot of water.
Yeah, we'll try one of these.
It's going to need to be the secondary site.
What time do they open?
8 o'clock. Or we're best with a crew.
I'll have a crew.
Yeah.
Please, mate.
Okay.
Alright, mate. Just pop you on the floor. Yeah, you do. Get on the floor. It's in the air. Yeah, get him on the floor.
He went into VTAC. I think VTAC. So see his arm lifting up? You ever seen that? Right. Looks like a seizure. You wouldn't know unless you were checking for pulse or had him on a monitor. But why would your STEMI patient have a seizure? Right? Why would your chest pain patient have a seizure?
Hello, can I have an ambulance please at Leeds Bradford Airport, the air ambulance space please?
Connect electrodes.
Alright, Chris. Go on, kid. Go on, Chris.
Chris?
You with us, mate?
He does fine. He does. Oh, I thought it was the end of the clip. Sorry. Spoilers. Didn't want to spoil a 20-year-old TV show for you.
Chris, it's James, you're at work. It's just oxygen, it's just James, you're at work. Just relax.
Alright, Chris. Alright, mate. You're okay. You're at work.
Yeah. So he does fine. But like, I mean, for all the world, like that looked like he was seizing, right? Like the arm and stuff. Like you wouldn't know unless you had him attached to a monitor or you were immediately thinking to check for a pulse. Yeah. In this guy, no. So in this guy, he was having chest pain, so he was probably having ACS, not clear whether it was a STEMI or not, but the ischemia caused him to deteriorate into VTAC or VFib. And at that point, he was having syncope, which was why he was having those kind of like movements that we saw before in the vagal patients as well, which then became prolonged, really bad syncope, requiring CPR. But hypoxic seizures are definitely a thing. I had a clip of a free diver, but I took it out because I was talking more about like the cardiac stuff. But there's a guy who's free diving, comes off hypoxic, and he's like twitching, and then it's like someone flips the light switch once he takes like a couple deep breaths, and he's like, "Whoop," and he's totally fine.
That's the most comfortable.
This is from Bondi Beach Rescue.
Really deep, slow breath.
Hey,
I love how they have to
Rick,
do
can I just have
subtitles
those
because it's
stats
Australian.
Again? Who is he? What age?
Have we got an age? 54.
Yeah, whip it to Nicola. It's slowly getting worse, so just tell the ammo to be ASAP.
Yep, Ambo's on the way, boys.
Slowly get you onto your back. What we're going to do is apply the defib machine. Does that feel there worse? Yep. We're going to do is put it, chuck it on. There we go.
The defib is a piece of equipment that shocks the heart back into a normal rhythm. You know, the worst case scenario is we're going to have to zap this guy back to life.
Just try and relax there.
We're actually trained not to put the pads on straight away, but all the signs and symptoms were there. You know, it was a really big chance that he was possibly going to have an arrest. 3 or 4
So these guys are
just
lifeguards.
waiting, anticipating the worst was about to happen.
And then you got the ambulance crew showing up.
I'll go up and meet it.
He's in a lot of pain. He's obviously got a lot of chest pain. I feel a bit sorry for him, but the ambulance has arrived now, so hopefully we can get him to hospital pretty quick. Oh, God, I'm starting to go out.
Pardon?
Where's that? I'm starting to faint.
Faint?
Was he breathing
Open your eyes.
Okay. Again, watch the arms before they shock him.
We witnessed the arrest, and it was just like, oh, shit.
If he stopped breathing and his heart stopped pumping, he's in cardiac arrest.
Health. Analyzing heart rhythm. Do not touch the patient.
Get that on for me.
Yeah.
Who among us has not had that internal
Yeah.
dialogue?
Hands are going.
Wait, analyze.
Shock advised. Charging.
The red button.
Red button. Everyone clear?
So he's already like got his
One
arms like
delivered.
postured
It
in
is safe
before the
to
shock's
touch the
delivered.
patient.
All right. Someone
Begin CPR now.
Someone get on the chest. Someone get on the chest.
Yeah, I'll get on.
Continue. Continue for one.
You can kind of tell from the quality of the compressions as well as the video clip. This is much newer, but like he also does fine. Okay. Yes. Yes. So does the arrhythmia cause a hypoxic event that then causes the arm movements? So the arrhythmia causes hypoperfusion. So technically the cells are hypoxic because they're not receiving blood that has the oxygen on them, but the patient is not hypoxemic because their oxygen saturation would be normal. Does that make sense to everyone? Like yes. Well, it's so the spasm, it's not a muscle spasm, right? It's this is not muscle spasm, this is neurodriven. So this is the brain getting angry that it's not receiving enough fuel. A way to think about seizures, I should have led with this, because we all understand like the cardiac stuff, and like you can have one area of the heart firing too much, and that's just like having PVCs. And then you can have generalized too much firing, which is like your VFib, VTAC, right? So when you have a focal seizure, that is one part of the brain firing too much. That's like your PVCs. And then when that spreads and you have too much firing all over the brain, that's VFib, VTAC in the brain. And when all of those parts of the brain are firing, you can get these weird uncoordinated motor movements, which is the convulsions that we see. And so much like the heart, you can have an ischemic event that causes the arrhythmia, right? Because you're pinching the fuel line, and so the motor starts misbehaving. Similar to the brain, if you have an arrhythmia, now it's not getting perfused enough. So the brain, you're pinching the fuel line, and it's going to start misbehaving. And that misbehavior is what the seizures are. Hopefully that makes sense. Okay. Right. This is another Bondi rescue clip, but this is like 20 years earlier.
A man's found floating, lifeless in the surf. His name is Takahiro Ono, an English language student from Tokyo.
So the question is, like, did he drown and
No
lose
one knows
consciousness?
what's happened to
Did he
him
lose
or how
consciousness
long
and
he's
then
been in
drown?
the water.
Did he lose consciousness because he had a seizure while he was in the water? Or did he lose consciousness because he had syncope while he was in the water? Or is he having really bad prolonged syncope?
Oppo can't detect a pulse.
Bagging, come on.
He's not breathing.
Bagging, come on, come on. Bagging.
Tucker is clinically dead.
You grab the knife.
The boys must get his heart beating again and air into his lungs.
It's a male, about 20 years old. They got him on the bag now. I'll get back to you in the morning. I can't really feel that.
Danny arrives with a defibrillator as Corey starts CPR.
1, 2, 3.
Again, you can tell the arrow from the CPR.
6, 7, 8, 9, 10, 11. Get a towel, get a towel. Yeah, I got it.
Tucker still has no pulse.
Stand clear, stand clear. Watch out. Everyone stand clear. Stay clear. No touching.
Okay, see again with those arm movements, kind of that posture.
Ready?
Kind of, I've heard people call it the
The
chipmunk
machine reads Tucker's vital
when they're pulling the
signs.
arms up like that. It's also a really good example of agonal breathing. You see the tongue just kind of going like.
Check pulse. If no pulse, give CPR. Check pulse. If no pulse, give CPR.
I can't get one. Start CPR.
The defib doesn't work on Tucker first time.
3, 4, 5,
The machine needs time to recharge. Corey continues CPR.
11, 12.
The ambulance has been called. Paramedics are on the way. Just if you need anything else, give us the yell.
Yeah, copy that, Chapo.
12, 13, 14, 15.
It's 4 minutes since lifeguards got to Tucker.
1, 2, 3, 4, 5, 6, 7, 8.
The machine needs time to establish whether he has any heart rhythm.
Stand clear.
There's a really good look at the agonal breathing.
Analyzing rhythm.
Tucker's had
And
2
again,
shocks.
still with the posturing, and
He's in
he's still
spasm.
moving a little bit, right?
Patients rarely survive if they need more than 3 shocks. Tucker's been clinically dead for at least 4.5 minutes. He has 1 chance left.
I've lost it.
Stand clear.
Stand clear, stand clear, stand clear.
Do not touch patient. Analyzing rhythm.
The 3rd shock has finally had an effect.
Not touch patient. Analyzing rhythm.
I won't shock again. Trying to breathe. Still stand clear, stand clear, stand clear.
Analyzing rhythm.
Breathing, yeah. It's all right, mate, it's all
Check
right.
pulse. If no pulse, give CPR.
He's got a faint pulse. He's breathing, mate. It's getting stronger. Take a good pulse, take a good pulse here. You've been in the water, and you swallowed a lot of water.
So that's sort of like cardiac causes that can cause lots of consciousness plus convulsions or twitching. Okay, so now let's talk about epilepsy, or a true seizure, right? This is the actual neuronal activity that you would see causing that generalized shaking. So patient loses consciousness and then has full body rhythmic shaking for about a minute. What kind of seizure did they just have? Grand mal, tonic-clonic, generalized motor, petit mal, or absence? Many people mostly going with grand mal. So, as of 2017, there is a new taxonomy or way of describing seizures that focuses on the onset. So, when it started, were the symptoms focal, like in an arm, or was it generalized, everywhere at once? And if it was focal, was it associated, were they aware during the seizure? Because you can have a focal seizure with awareness. Like patient can have their arm twitching and be like, I'm definitely having a seizure because I'm not doing that, right? And that can then progress into a generalized seizure. And they can also lose consciousness and just have the one arm twitching, right? So focal onset with or without loss of awareness or impairment of awareness. And then generalized onset is always associated with a loss of awareness or impaired awareness. And then you just describe what the motor activity was. So you have a generalized seizure with impaired awareness and no motor activity would be what we used to call an absence seizure. But this is this is much more descriptive, right? Because it's like, so you already know everywhere all at once, they were not aware of their surroundings and there was no motor activity. The idea is we're trying to get away from one word things, 1 or 2 word descriptions, and get to something that's just say what actually happened instead of having to decode it into whatever language we're using. So basically, did it start in one place? Did it seem to start all over? Was the patient aware or not? And just describe what the motor activity was. Is the most accurate way, which honestly is easier because all you're doing is just describing what happened. Okay, so this is the new method as of 2017. So coming up on 8-10 years new of how to, yeah, I know, right? Of how to classify seizures. So what can trigger a seizure? What's that? Strobing lights. Okay, good. Photo. What else? Sorry? Hypoglycemia. Yes. Smells. Claire? Okay, bad sleep, bad PO intake. Anything else? Stress. Yeah. Okay. Drugs. Any kind of physiologic stress. Okay, so the things that I normally ask about are acute infection or illness. Right, that's pretty classic. When someone comes in, they're like, oh, I had a seizure. I haven't had a seizure in a couple years. Okay, how have you been feeling lately? Oh, I've had a cough, shortness of breath, chest discomfort for about a week now. Like, okay, you have pneumonia. A lot of this in COVID. COVID patients that have a breakthrough seizure. Kind of OG COVID, not so much now. Sleep problems, dehydration, poor PO intake, all the other stuff you guys mentioned. Strobing lights, photo seizures. I forget what the percentage is of people that are photo sensitive. And being off their meds for whatever reason, whether it's they're not taking them, the side effects are too bad. Anti-epileptic medications can just have like a very wide range of horrific side effects. Other stuff can happen, changes in people's kidney or liver function over time, even if they've been on the same dose for years, means that they're no longer on an effective dose for what's changed for them. Or they can't get it, they lost their insurance, I can't get to the pharmacy, I got hurt and there's no one to bring me my meds. Probably not taking the meds or inability to get the meds is the most common reason. If I had to rank them in what I see in the ER, it would probably be tied for first place is acute infection or illness and being off your meds. And regardless, I still always put acute infection or illness sort of like near the top because in the ER, that's what I need to look for. Right, okay, you had a breakthrough seizure, you're fine. Like I'm not worried about the seizure. I'm worried about missing what triggered the seizure. So that means I need to do an infectious workup and find the infection or find that you don't have one so that I can get you the appropriate treatment and make sure you don't have another one. Specifically with pediatrics, because all their stuff is weight-based, they have a growth spurt, they could outgrow what their dose was. To be honest, though, pediatric neurologists are super, super on top of this, so it's pretty uncommon, but it does happen. In trauma, right? The head whack, the head bonk, and then they have a seizure. That's more of like a direct injury brain impact thing, almost like commotio cordis, but like for the brain. But it could also be associated with bleeding around the brain, right? Because blood is very irritating to the tissues. So if you have bleeding around the brain, that can irritate the tissues and directly sort of cause that irritation then that leads to brain ectopy, which is seizure. Yes, definitely. So new mass, tumor, mets, if they're a cancer patient, and like they're being treated for cancer, it's not usually So I don't know what the numbers are. I'm just only speaking kind of from my experience, is that it is usually not the primary lesion. Usually they have a history of cancer. And then I'm looking for a MET to the brain when I get a scan of their head. All right, so study we're going to talk about, the Rampart trial, very famous study, which is rapid anticonvulsant medication prior to arrival trial, Rampart trial. This is a study of IM Versed versus IV Ativan for pre-hospital seizure. So what's your go-to Versed route in the field? What are you doing? IV, IM, nasal, no preference. First available, it's like getting a table at a restaurant, inside or out, whatever's first. Okay. So some preference for IM, otherwise kind of split between IV versus no preference. Similar online, Renee?
Yep.
Okay. Same. So for this study, the population was EMS patients in status epilepticus, which I forget exactly how they defined that, but it was a reasonable definition. They had 893 patients in status. The intervention was IM Versed 10 milligrams. And the comparison, which was considered the standard of care, was IV Ativan 4 milligrams. And 4 of Ativan and 10 of Versed are considered kind of like equivalent doses of benzos, although it's hard to, you can't really exchange one currency for the other the same you can between like fentanyl and Dilaudid and morphine, and we really know kind of which are supposed to be equal. But those are considered equivalent. And the outcome was termination of the seizure before arrival in the ED. Okay, so here's what they found. Time from active treatment to cessation of convulsions. So that means from the time my finger is on the plunger pushing the medication in, how long until the seizure stops? IV is faster, not statistically significant. Now, the time from, I'll go to this one next. The time from box opening to the treatment actually happening is understandably longer in the IV arm and shorter in the IM, right? This is saying from the time that I open the box to give the med, it is faster to give an IM injection than it is to start an IV and then give the IV injection. Duh, okay? So the net result between those two is, so that is then the time from we open the box, select our route, give the med to the time the seizure stops. And so IM is a little bit faster, but in this study was not statistically significantly faster. So what they determined was that IM was non-inferior, which means when you do a non-inferiority trial, there are usually other advantages to doing something. So you're like, well, it's not worse in terms of the clinical outcome, but it's better for other reasons, right? So if you do a non-inferiority trial for an oral med instead of an IV med, it's like we don't have to give the IV, right? Like I don't have to tie up a nurse and then getting the IV and their difficult access and blah, blah, blah. No, just throw a pill at them and it's the same, right? So there may be other advantages. And so in this instance, what is considered the advantage for IM is that you're not you're gonna have like a higher success rate, right? Because you can always give an IM shot. You may not always be able to get an IV, right? I would say the risk of a needle stick, trying to start an IV on a patient that's in status, versus everyone hold down this arm, I'm gonna give IM shot. I think that keeps us safer. So there are, I call them, we like to talk in research about patient-oriented outcomes. I call this a provider-oriented outcome. Like, I am at lower risk of getting a needle stick, and so if the two treatments are similar, I'm gonna pick the one that's safer for me, okay? And so this is one of the main reasons that I recommend IM up front. And also, I think if they continued this trial out, probably IM would end up being faster. But that's where the data comes from for why we recommend IM like over IV, and that's why. So the bottom line is that there was no difference, and so they were considered non-inferior, but I put that asterisk because of the stuff we discussed. Nasal. I think the absorption is could be quite variable depending on their nose, and especially with kids and snotty noses and stuff. I'm not as familiar with the data because there hasn't, that I'm aware of, been as large of a landmark study as the Rampart trial for nasal. So it's a totally reasonable option, but you have to give a lot of medication. And with the concentration, sometimes that can be challenging with what the volume is that you're then giving. So I'm not sure that giving a nasal shot is any faster than giving an IM shot. You know, with nasal, there's zero risk of needle stick, which is certainly an advantage. I think I would err on the side of muscular rather than nasal, just personally on my take on the data. But nasal is also a totally reasonable option. That is why it's in the protocols. So reviewing the seizure protocol, you guys know this. It's, you know, unfortunately 5 of Versed. I think it should be 10. Maybe I'll submit that to MSC for this coming cycle so it can get argued about with your repeat dose. One thing I want to point out that I didn't remember this when I was looking through the protocol. If a patient has a vagal nerve stimulator, you can suggest the family use it or assist them if requested. And you just pass a magnet over it every 3 to 5 minutes, a total of 3 times. Okay, just don't turn off their defibrillator. Because surprise, they were in VTAC. No, right? It's like right. So the other one, EMTs at all levels of certification may assist the patient or caregiver with the administration of the patient's own physician prescribed benzos in whatever preparation it's dispensed in. For example, the patient may have rectal or nasal dosing preparations of diazepam. So diazepam is not in the protocol, but particularly with kids, they have rectal diazepam. It's called Diastat, that the parents are told to just put it up there. And that's really all there is to it. But you can, remember, if you're an EMT basic, this allows you to do that, okay? So, right, just make sure it's going in the right orifice. And you laugh. I've seen tubes get all kinds of places incorrectly. You know, even if you're an ET basic and you don't have ALS, but the family has a medication that they're supposed to administer, you're allowed to help them give that. Okay. And then a reminder for pregnant and postpartum patients, you can have postpartum eclampsia. So if the patient recently gave birth, they can have eclampsia. I think the risk is out to like 6 or 8 weeks postpartum. And then we're still giving the Versed and stuff, but then we're giving MAG and we're kind of going down a whole different route, right? So I want to highlight, you drop the meds and the patient's not seizing anymore. There is not a benefit to the patient of giving post-ictal benzos. It does not actually prevent the next seizure. Yes?
Does that mean that punch and take effect and I use them on myself? It only seems fair.
You, or depending how agitated your partner is. Okay. Just put okay per Metcon 200. Yeah.
I've already got a scan.
Good. So the exceptions for this are patients that you suspect are having alcohol withdrawal, right? Because they need more benzo. That's what caused the seizure, right? This wasn't something else that irritated the brain into having an episode of brain VTAC that then stopped on its own, right? Like you don't shock in between episodes of VTAC, right? The same reason we're not pushing the benzo in between episodes of seizure, unless this is fueled by acute benzo deficiency, which is alcohol withdrawal, or stimulant intoxication, cocaine, meth, that was fueling the seizure, in which case we need to put the brakes on the brain because that was all that getting ramped up is what was causing the seizure. Now, for someone who is agitated after having a seizure, and perhaps they're confused and combative, and now it's becoming a little the scene is potentially dangerous, so they're almost like edging on something that would be behavioral. if you weren't certain that they were having a seizure, I would say that ketamine is still the ideal agent for that, okay? And let me tell you why. So what happens in the brain, we have a couple neurotransmitters. We've got one is, so what happens in, well, we'll just talk about the ketamine. So you've got GABA, which is a neurotransmitter, which GABA puts the brakes on the brain, slows everything down, okay? You've got glutamate, which puts the gas, okay? Makes everything speed up, more activity in the brain. Benzos are a positive effect on the GABA receptor. It is stepping on the brakes, okay? Ketamine has a negative effect on the glutamate receptors. So this is lifting off of the gas. So both of these will have the net effect of slowing down the car, because that's what the problem is, right? The engine, the brain is at red line in the moment of seizure. And so we need to slow the engine down, right? So we're going to step on the brake and come off the gas. Ketamine is still, I think, the ideal agent because you will still get rapid control of bringing down the brain activity, calming the patient down without the risks of respiratory depression, et cetera. And ketamine is showing, even for acutely seizing patients, this is not in the protocols yet, this is outgoing research and new practice patterns that I am seeing from specialists, appears to have some very good anti-seizure properties. And every time that I have had a patient that was in status that I have given 10 plus of Versed, I've given them Keppra. The next thing I'm doing is I'm giving them a big slug of ketamine. And when I have talked to neuro ICU attendings, that's their practice as well. That's who I stole it from. Is they're usually starting the patient on a ketamine drip and then admitting them to the ICU for monitoring. They're like, there's not a lot of great research on it. They're like, but it sure as heck seems to work. Okay, so ketamine is a really good drug if you got this agitated patient. Still, ketamine is still, I think, the ideal sedation agent for that. It's still going to have good anti-seizure properties, and it's still going to calm the patient down in the safest way possible while maintaining the respiratory drive and everything. Yes. Yes. The protocol does say, I think, did it say any route? It said, I think it said any route. Yeah. It says any route. So the protocol says. So, but again, like it still comes down to your own comfort level. If you're like, right, if it says like, now give intracranial benzo, just shove the needle right through the head. You're like, I don't think I should do that. Then don't, right? Okay, it's fair. Right, it's intercardiac benzo, just full on Pulp Fiction, right? Like, so let's talk about status epilepticus. So status, defined in the protocol as seizure greater than 5 minutes. This isn't in there, but I'm going to add it. Multiple seizures without returning to baseline. Okay, so if they have multiple episodes without coming back to normal, that's status. I also say with response times and stuff as they are, if you get on scene and the patient's still seizing, they're in status. Okay, so you're gonna have convulsive status, which is obvious because they're still shaking. Yes. The behavioral dose. Yeah, so that's what, up to 4 per kg IM. Yeah, up to 4 mg per kg IM. You can have convulsive status, which is obvious because you still have the motor activity, or you can have non-convulsive status, which means they're still seizing, but there's no motor activity. And so there's not a good universal definition for this, but in general, it's going to look like a prolonged postictal period, or the patient is really just like not returning to baseline. So other things kind of that could be happening here, if you're thinking like coma, stroke, like what the heck is going on with this person? Like they had a seizure how long ago? And they're like really not recovering. This is kind of weird. They're not following the trajectory that I am accustomed to. Could be non-convulsive status, okay? Now, that can be hard to diagnose, but that's why Mercy has this great thing called the Cerebell, which is a point of care EEG that gets applied to the patient in the ER, and we're able to monitor the patient while they're in the ER for a period of time, effectively in real time with an epileptologist to determine whether they're having seizure activity. And we have Amy here, who is our product rep, who I've invited to come and kind of show us a little bit about the tech. Yeah. I'm going to throw this on you just while you talk so the people online can hear you. Okay.
All right. So this is the Cerebell device. It's a headband and it's a recorder right here. When a patient needs a Cerebell, they're going to come to Mercy. The nurses are going to grab a measuring tape, measure their heads. There's 2 sizes, but they're in a box like this. Basically, they just pull out the pillow, roll up a towel to create some space around the back of the head. And this is what the headband looks like right here. It's a 8-channel, 10 electrode headband. These are filled with EEG gel. So they basically just go around on the head like this, right around the back, 1 and 6 clip above the eyebrows. And basically all they do is they twist these a few times to part the hair, prep the skin, squeeze out the gel that's in each one of these, connect it to the device. This is where they will put in all of the patient's information, but they leave it on a seizure burden screen. It's hard to see, but this is what it looks like. The seizure burden is the % of time within a rolling 5 minutes there's been any abnormal epileptiform activity. So if there's a percentage here, that's telling you it's picking up some activity, something's going on. So if it's at 50%, that's 2.5 out of the last 5 minutes. And then once you get to 90%, which is 4.5 out of the last 5, they get this alert. It's a little bit louder on the real devices, but this doesn't shut off. This is telling you patient is in status. It actually has FDA clearance for a diagnosis of electrographic status epilepticus, which is when the seizure gets to a continuous 10 minutes or 12 minutes in the last 60. So you can be pretty confident that when you get these alerts that patient is in status. What else?
I'll check a little bit more. So on our end, do you want to pass it around for them to look at it?
You guys,
Okay, like,
does anybody? Yeah, of course.
Yeah. So on our end,
pop out the gel, you can.
what we're doing is when you can check to see if your brain dead if you want.
Here.
Oh, yeah, I'll take that. It's just a magnet.
Oh.
Mercy is the only facility in the area using this. This is a Mercy exclusive, and there's one more reason why we're better than Bay State. So that's just the one reason. Believe it or not, when I keep talking about tropes, it's on that slide now. So what happens on our end is when we initiate the use of this device, we're also letting one of our neurologists know, and they're monitoring the stuff in real time. We'll talk about like a couple, we're going to get to the cases shortly, but I'll talk really briefly about a case that I had. EMS wasn't involved in this directly, so I didn't include it in here, but just how the Cerebell really changed management in this patient. I had a patient who had a history of pseudo seizures, which we'll also talk about in a minute, who was there for acting up at the home they're from. I forget what the setting was. It was a group home or whatever. You've all been on that scene, right? And they had a seizure back in Aquapod. But for whatever reason, this occurred before I came on shift. For whatever reason, the PA who was taking care of them decided to treat it as a true seizure. They were like, something just seemed a little off about it. So I gave him benzos and I threw him on the Cerebell. That patient had a formal diagnosis of pseudoseizure, had not been diagnosed with epileptic seizure. Put up the Cerebell on them. They were in non-convulsive status. Okay. So we initiated treatment to get them out of status and then had to ship them to a specialty hospital where they could, it was a pediatric patient, so they had to be able to see a pediatric epileptologist to get this treated. But that was a new diagnosis that could have very easily been missed if that patient had gone to Bay State, right? Because we have access to this and they do not. Yes, question. Will it ever come to the field? I don't know. That sounds like a good study. Amy, you want to give me like 10 of those for free and we'll make it happen? Possibly in the future. Yeah, it's an ongoing research question that would have to be looked at. You know, I'm sure it ain't cheap. So we'd have to figure it out because again, with a lot of the stuff that we want to do in the field, that's like more advanced scope that ends up being more costly, like blood transfusion, there's no additional reimbursement for it. It calls still just like BLS, ALS1, ALS2, IFT, CCT. You can't get any extra money for doing more. So correct. Yeah, but yeah, correct. If you were, and you don't have the duration of time to initiate this, but it would be interesting to see how much you can determine even in just the 15 to 30 minutes you are with the patient. If you have a suspected seizure patient, you slap it on along with the cardiac monitor up front, like what would it tell you? That would be an interesting question. But yeah, Amy. So what Amy is saying is that often within the first 5 minutes that they can get enough information to formally diagnose status epilepticus, as well as the risk for ongoing seizure based off several studies that have been done recently. Yes. Yes, it's available 24/7 at Mercy. Yes, bring them to us. No, because you're like, I'm concerned about non-convulsive status, so I brought them here because you have the Cerebell and Bay State doesn't. Yep. Yeah. Yeah. So yeah, Amy just mentioned that nurses are getting retrained on this monthly, so they're very aware of it. And I think, frankly, we underutilize it. The only downside is that if I'm getting a CAT scan of their head, I try to get the CAT scan first and then put it on them because it'll interfere with the CAT scan because you got metal around their head. But that's not a big deal, right? I can say, get this person over there next, and then we'll put the Cerebell on them. That's not a big deal. Yeah, and we can't always take it off and reapply, right? It's not a big deal. So, more questions about the Cerebell non-functional status? Yes? How many do we have? Yeah. Okay. Yeah. Yeah. So we have 2 in the ED. I'm sure they'd have no problem selling us more of them. So. All right. So let's move on to talk about functional seizures. Functional seizures is the seizure formerly known as pseudoseizures, psychogenic non-epileptic seizure, false seizure, dissociative seizure, non-epileptic attack disorder. So you know what we're talking about. This is now called a functional seizure as to bring it in line more with other psychiatric that are called functional diagnoses, where patients have symptoms that are a physical manifestation of their psychiatric illness that is not volitional, right? They're not doing it intentionally, but it is an outward display of their underlying psychiatric illness. So I want to highlight, it is not intentional. They're not sitting there thinking I'm faking a seizure to get attention. That's different. That's called malingering. Not malingering. And the thing that is super unfair about this is 10 to 15% of patients with a formal diagnosis of functional seizure also have epilepsy. So they can have both. And so sometimes they're going to have an epileptic seizure, and sometimes they're going to have a functional seizure. Right? Totally unfair. So some of the ways for kind of differentiating this, functional seizures tend to be very steady with variable amplitude of the movements, so about like a steady frequency. The functional seizures do. The epileptic seizures have a decreasing frequency of movement and amplitude over time. The eyes are often closed in a functional seizure, the same way that we saw in the syncope videos, often open in an epileptic seizure. The functional seizures can be longer, whereas the epileptic seizures tend to be shorter. If the patient recalls the events, that would favor it being a functional seizure versus an epileptic seizure. They may not recall the event because of the loss of awareness during the generalized seizure. And a functional seizure will not have a postictal period, whereas an epileptic seizure will. So can still be difficult to differentiate between the two, but those are some of the factors you can use to try and tease them apart. However, you are still going to assume when this occurs that it is an epileptic seizure, and you are still going to follow your seizure protocol and treat the patient appropriately with Versed. Because again, even if they carry a formal diagnosis of functional seizure, 10 to 15% of them still have epileptic seizures, and they can be hard to differentiate. So just give them the benzo. It's not like you're going to leave them unseen anyway, right? Just treat them for the worst thing that could be happening. 10 to 15% is too high of a miss rate to err on the side of like, but you can also add on like the verbal reassurance and calming. For a patient that I was certain was having a functional seizure, I have talked them out of their seizure, which is where I said voice like Versed earlier. That's where that came out because the nurse said that to me afterward. So just, very low, calm, talking in the ear. It's like, I know this is very scary, but you're safe with me. I'm going to take very good care of you. Try to relax. I know this is very overwhelming, but we're in the ambulance. We're going to the hospital. You're going to get the care you need. You're safe. Try and relax. Focus on your breathing. And that can break the seizure. Because again, like they're not faking it. They're not faking it. This is not intentional. This is a physical manifestation of the underlying psychiatric disorder. All right, so to summarize, seizures. Loss of consciousness with convulsions. Your differential includes syncope, cardiac arrest, epileptic seizure, functional seizure. IM is at least as good as IV, if not a little better for the benefits that we described. And you're going to treat it as seizure as long as they still have a pulse. Okay, so let's move on to stroke. Well, what are the different kinds of stroke? Ischemic stroke, hemorrhagic stroke, others. Okay, yeah, ischemic, hemorrhagic, large vessel occlusion, posterior stroke versus anterior stroke, a TIA stroke, but I call it better. Monty Python reference for any of the fans out there. Thank you, thank you. See the heads nodding. I'm not dead yet. So let's talk about stroke scores. You got the Cincinnati pre-hospital stroke score, which is just face, arms, and speech. Notably, the Cincinnati stroke score does not care if you have legs. Okay, it is actually, in fact, only looking at arms. You have the LA pre-hospital stroke screen, which adds past medical history, age, seizure history, duration of symptoms, whether they're ambulatory baseline, blood glucose, and whether the findings are unilateral. That additional checklist actually dramatically increases the accuracy of the assessment. The RACE score, which is looking for aphasia, which is difficulty speaking, agnosia, which is like a memory, putting things together difficulty, face, arms, legs, and head and gaze deviation. And you've got FAST-ED, which is what you guys are most familiar with because that's what the MASS protocols use. So the Cincinnati score and the LA pre-hospital stroke screen, all of these tend to over-assess the anterior circulation of the brain, but these in particular are looking more at the anterior circulation. And the RACE and the FAST-ED score are designed specifically for identifying large vessel occlusions. And the reason for that is because of the treatments that are available, which we'll talk about in a second. So I'm going to talk about not just FAST-ED, but adding balance in eyes, or BFAST, to think about some posterior findings for stroke. Okay, so in terms of our stroke treatments, what are our treatments that are available? Why are we racing to the hospital? Fibrinolytics, okay? So we got clot busters, TPA or TNK, that's a 4.5-hour window. What else do we do? If that's a 4.5 hour window, why does the protocol say anyone within 24 hours should be called as a stroke alert? Mechanical extraction, neuroendovascular therapy. That's this guy over here on the left. So it's like a stent and like a rotor-rooter to get out the large vessel occlusion. That's why we care about the LVOs, because it's a different treatment that's available. It's not just the clot buster, it's mechanical clot retrieval or thrombectomy, and it can be done out to 24 hours, although realistically, they're not doing it past 16 because they have a very high risk of converting to hemorrhagic bleed afterward. So, stroke protocol, pretty straightforward. Determine they're having a stroke, get them to the hospital. I found this interesting. Elevate the head of the stretcher 30 degrees is specifically in the protocol. Not that I know anyone that puts the stretcher flat anymore because of where the life pack fits. But, you know, that used to be a thing. But this is actually a point of contention in whether the head of the stretcher should be up or down. There's ongoing research about whether it affects stroke outcomes or not. And so the thought is, if the head of the stretcher is up, then we're allowing venous drainage from the brain to be better. And so the venous drainage means that we can perfuse the brain better because there's no back pressure, right? But if we lay them flat, now the heart is not working against gravity, and maybe the heart can perfuse the brain better because of the less resistance from gravity. But now we're also having a little bit of venous kind of stasis because we don't have gravity helping to drain. And that's the thought process. And there does appear to be something there, but we don't know which way it actually lands. But there's ongoing research on to whether this head of the stretcher should be up or down. But I mean, like I said, no one in EMS is putting the patient flat, maybe unless you're BLS, right? So the point of entry plan, again, within 24 hours, other things to think about: dizziness, can't walk, double vision, weakness affecting the arms and legs. Again, that 24 hours for stroke activation because of the capability of a clot retrieval. So coming soon, this was discussed at the Medical Services Committee meeting last week. There is upcoming, they're going to be putting a change into the point of entry plan for patients with a FAST ED score greater than or equal to 6, which is pretty bad, right? That the patient will be diverted not just to the closest primary stroke center, but to the closest neuroendovascular center. The time windows are kind of to be determined on that, because what we don't want to happen is you're at the 4-hour mark and it takes you, and you're across the street from the primary stroke center where they could go and they could get TNK within 30 minutes. We don't want you to drive 30 minutes to go to the neuroendovascular center and then determine that the patient was not eligible for the thrombectomy, and then we miss the thrombolytic window, right? So it's patients that are right on that cusp that we're trying to figure out how are we going to word this. But this is in the pipeline, that FAST ED patients, or stroke patients with a FAST ED greater than or equal to 6 will be diverting to a neuroendovascular capable center. But the timing on when exactly, but if they're outside of the window, when do they go or not, like that, they're still working that out. But this is in the pipeline. Correct. Yeah, that would be base date when they actually have the service available, because there's a lot of times that they're not available, which raises the question, are they going to be, you know, the same way that you say, you know, CT scanner down stroke diversion, OR down trauma diversion. Are you going to say that, you know, we're neuroendovascular down, and so we're not, like, you don't need to bring the patient here? I don't know. That's all to be determined. St. Fran, probably Worcester, depending on where you are, this could be equidistant. But I mean, that's hard. So the other problem, it would have to be Worcester, because they were talking about this like out in like the southeast part of the state and like Rhode Island. After the plan is implemented, then the department can certify individual hospitals for mass services to take them to if they're on the border outside of Massachusetts, but they cannot upfront in the point of entry plan take the patient to a hospital that is outside of the state not regulated by Mass DPH, right? So they can after the fact then say that. Like if you're closer to the hospital in Rhode Island, because that's where you are, then go there, right? But because they already do that with STEMI, So there's a workaround for that. They'll have to do it once it's kind of implemented. All right, so our neuro summary for seizures, you've got loss of consciousness, syncope, cardiac arrest. If you learn nothing else, I want you to, when you're thinking a cardiac patient, then it looks like they seize, check a pulse, okay? Functional seizure, epilepsy, all this other than cardiac arrest are going to be treated as seizure. Start with IM first. Unless you already have a line, again, it depends on what your manpower and the crew configuration is. Obviously, if you're a medic basic and you're the only ALS provider on scene, I'm going to go IM. I'm not going to fart around with an IV up front, right? But if you're medic, all the time, you've got an ambulance and an engine on scene, you've got 6 paramedics, more people than you know what to do with, the patient's probably going to have 2 lines by the time you get him attached to the monitor. Give an IV, sure, whatever, right? Like, it depends on the resources and the system of the company that you work in. But my personal preference is going to be for IM if the patient does not already have access, and especially if I'm solo. Our stroke scores tend to I don't want to say over-assess, but they weigh very heavily the anterior circulation of the brain, not the posterior. FAST-CT looks for LVO, but if you add balance and eyes, so balance problems, can't walk, and these patients, like, remember, posterior brain is what's affected by alcohol, okay? So if they're like stumbling, like they're drunk, but they're not, and they're having that kind of like lack of coordination, that loss of coordination, that's posterior stroke until proven otherwise, as well as eye issues, blurred vision, double vision, and we'll talk about that more in some of the cases. Stroke activation up to 24 hours, and there is a point of entry update coming soon. Questions about that? All right, went a little longer than I intended. Let's take a quick break, say 5 minutes. Just a quick 5-minute bathroom break, then we'll come back and we'll jump into the cases.